This is a 32-year-old lady evaluated for pain abdomen, underwent left ureterocele incision in 2017 elsewhere. She presented to us. Her CT showed left renal duplication with upper pole hydroureteronephrosis till the bladder and non-functioning upper moiety confirmed on DTPS scan. Her cystoscopy showed normal right ureteric orifice, double ureteric orifice on the left with evidence of ureterocele incision at near the bladder neck. She was planned for left lap heminephrectomy. Standard ports were placed. We prefer open Hassan's technique for the first port at the iliac fossa, after which other working ports have been placed. Then the descending colon was mobilized starting from the line of Toll. The omentum is mobilized completely. Peritoneal folds are dissected, cut and separated. The bowel mobilization is one of the most important part because the mobilization of the bowel gives us a proper visualization of ureter, hilar structures and the kidney. Care has been taken not to injure the bowel by harmonic or the thermal instrument whatever we use. The bowel has been reflected completely from down below till the spleen. The distal bowel mobilization is done almost up to the iliac brim. Later the ureter is planned to be dissected as much as possible, and it has been decided not to go up to the bladder because there is the incision of the ureterocele what has been seen on the cystoscopy is very close to the bladder neck. Though there is a chance that a small stump of the ureter will remain inside, but chances of having UTI is less and the patient has done well. She has no recurrent UTI post surgery. After the dissection, now it has been seen that there is proper mobilization of the bowel, and you can see the two ureters, the dilated ureter completely and the gonadal vein. We try to keep the gonadal vein more distally or laterally so that we can find the ureter better. Care is always taken in duplicated systems not to injure the vascularity of the normal ureter. Care is utmost important to keep the ureteric sheath of the normal ureter. Most commonly at the distal part of the ureter there is a common sheath, and chances of injuring the vascularity of the normal ureter increases more distally. Once we identify the ureter, both the normal and the hydronephrotic ureter, then the ureter is dissected and separated out, taken more proximally, more towards the hilum. At this phase it has to be very precise and care has to be taken not to injure any aberrant vessels going to the lower pole of the kidney. Here we can see there is a vascular structure crossing over it and going to the lower pole. So it has to be preserved because the lower polar vascularity, the vessels, they mostly supply the upper part of the ureter. Any small vascular bleeding or small twigs that can be cauterized. Secondly, the pelvis, which is identified now, has to be pulled up. Now the upper polar dissection is done. Here we can see clearly the renal vein. Then we have to check for the adrenal and adrenal vein. Adrenal is seen clearly now. In between the adrenal groove and the kidney, there is a plane is created, and that plane has to be extended upwards to find the normal kidney, normal parenchyma upwards. At this phase also one has to be very precise not to injure the renal vein. There are branches of renal vein which may cross over it. The adrenal vein, that has to be kept in view. Most of the times the upper pole moiety, which is non-functioning, is very small, and that can be tackled when it is dissected from below, and most of the part comes down. The kidney almost flips and rotates downward, and it can come down. Sometimes the more hydronephrotic kidney, that may require a separate incision on the peritoneum and dissection at the upper part. Now the ureter is dissected distally. We dissected up to the pelvic brim and beyond that. After that point, we saw the common sheath, both the ureter fusing completely, so we stopped there. Here the upper pole is dissected now, the hydronephrotic part. The video is little speed is increased at 2x. Once this has been done, we give a puncture at the hydronephrotic kidney, so the stored urine has been drained, and it is easy to pull the membranous parenchyma of the non-functioning kidney. Now the ureter at the distal part is clipped and cut. Then we pulled out the ureter completely behind the hilum to the upper part. We deflated the ureter further so as the ureter can easily come out behind the hilum and easy to dissect and cut. Most of the times the thin parenchyma layer that peels off from the normal upper polar kidney, but at some places there are adhesions, and we try to take out completely, but at one point there is 1 to 1 centimeter of membranous parenchymal wall is completely attached, so we left it, and that has been fulgurated so that the secretion should not come, and drain has been placed. Patient did well post-operatively. After 2 days he has been discharged, and post-operatively she is good.